As per the Canadian Health Agency of Canada, June 2022, and according to the 2019 Canadian Health Survey on Children and Youth, 1 in 50, or about 2% of Canadian children and youth between 1 to 17 years of age, were diagnosed with ASD. As noted by Meich and Hall 2016, research shows that early diagnosis of and interventions for autism are more likely to have major long-term positive effects on symptoms and later skills. Early interventions in ASD are evidence-based practices, procedures for which researchers have provided an acceptable level of research that shows the practice produces positive outcomes for children living with ASD. Early intervention should happen as soon as possible after a child's diagnosis. It may include speech therapy, physical therapy, and other types of services based on the needs of the child and family. Autism spectrum disorder can sometimes be diagnosed in children before they are 2 years of age. Some children with ASD whose development seemed typical up to that point begin to regress just before or sometime during the age of 2. Early interventions occur at or before preschool age, as early as 2 or 3 years of age, actually. In this period, a young child's brain is still forming, meaning it's more plastic or changeable than older ages. Well, because of this plasticity, treatments have a better chance of being effective in the longer term. Early interventions not only give children the best start possible, but also the best chance of developing to their full potential. The sooner a child gets help, the greater the chance for learning and progress. In fact, recent guidelines suggest starting an integrated developmental and behavioral intervention as soon as the ASD is diagnosed or seriously suspected. Meichin Hall, 2016. Applied behavior analysis is a therapy based on the science of learning and behavior. According to Meichin Hall 2016, behavior analysis helps us to understand how behavior works, as well as how behavior is affected by our environment, and how learning takes place. ABA therapy applies our understanding of how behavior works to real life situations. The goal is to increase behaviors that are helpful and decrease behaviors that are harmful or affect learning. Autism Speaks 2022 notes that ABE therapy programs can help increase language and communication skills, improve attention, focus, social skills, memory, and academics. Can also decrease problem behaviors. The methods of behavior analysis that have been used, they've been studied for decades. They have helped many kinds of learners gain different skills, from healthier lifestyles to learning a new language. Therapists have used ABA to help children with autism and related developmental disorders since the 1960s. How does ABA therapy work? Applied behavior analysis involves many techniques for understanding and changing behavior. ABA is a flexible treatment. It can be adapted to meet the needs of each unique child. It can be provided in many locations, at home, at school, or anywhere in the community. It teaches skills that are useful in everyday life and help children reach their full potential. It can involve one-on-one teaching or group instructions. What does an ABE program involve? Well, good ABE programs for ASD are not a one-size-fits-all. ABA should not be viewed as a canned set of drills. Rather, each program is written to meet the needs of the individual child. And as we've learned, every child is unique. And as the saying goes, you've met one child living with ASD, well, you have met one child living with ASD. The goal of any ABA program is to help each person work on skills that would help them become more independent and more successful in the short term as well as in the future. We want to help children reach their full potential. Aunt Baba 2018. Aunt ABBA stands for the Ontario Association for Behavior Analysis. In its 24 years of existence, Aunt ABBA has developed into the largest organization representing behavior analysts in Canada. During this time, Aunt ABBA has forged partnerships with families, government, and other organizations to advocate for improvements and the accessibility and quality of behavior analytical services for those in need. As a logical extension of its role, Aunt ABBA identified the need to produce a comprehensive examination of evidence-based practices and to make recommendations for the provision of behavior analytical services to children with ASD in Ontario. This undertaking reflects the organization's ongoing commitment to individuals with ASD and their families, and the belief that children with ASD have the right to the most effective services based on the best available evidence there is. In March 2016, the Ontario government announced that a new Ontario Autism program would be available in 2017. In response to that, Aunt ABBA formed the Ontario Scientific Expert Task Force for the treatment of autism spectrum disorder. Here's an acronym for you: OSETTASD, to examine the research, evidence, and accepted practice guidelines related to the effective interventions for individuals with ASD, and also to provide recommendations based on the synthesis of these information sources. So, in the fall of 2018, a caregiver brief report was created to accompany the comprehensive report. This report describes what is meant by the term evidence-based practices. It also identifies models of intervention that are considered evidence-based. It provides a summary of the existing research evidence for various interventions used with people with ASD. Comprehensive ABA interventions tend to address multiple domains or global outcomes and are delivered in an intensive format for a prolonged period of time. Focused ABA interventions generally refer to interventions that target a relatively small number of behaviors and skills selected for a change, and are implemented until the goals are achieved. Aunt ABBA, 2018. Despite the overwhelming evidence of the effectiveness of ABA-based interventions, some autism rights and neurodiversity activists have expressed concerns with ABA-based interventions. Concerns have included discontent with historical events and possible harm from the procedures and goals targeted by ABA-based interventions. The purpose of the study that we're going to look at was to examine some expressed concerns about ABA-based interventions. Originally from the Journal of Autism and Developmental Disorders in 2022, the authors of this study represent stakeholders from multiple sectors, including board-certified behavior analysts, licensed psychologists, parents, and autistic individuals diagnosed with ASD. I chose this peer-reviewed paper because I was concerned about the concerns regarding ABA-based interventions. As a student in Northern College, as I'm learning about ASD, we haven't really talked about concerns regarding ABA-based interventions. And as I noticed going through the study, the current concerns about ABA-based interventions are based on factual inaccuracies or outdated concepts. They're based on the way things used to be. And as we know, a steady stream of research and studies continuously informs our practices, especially when it comes to inclusivity and accessibility. The earliest version of ABA used punishments as well as rewards. Punishments are no longer used in ABA, but critics think it's still too hard on children because it's so repetitive. Another criticism is that ABA is too focused on eliminating behaviors instead of building skills. With that in hand, the benefits outweigh the concerns. Let's take a look at the benefits and the effectiveness of ABA strategies on the next slide. Originally from Current Psychology from 2020, the research titled Early Intervention ABA for Toddlers with ASD Effect of Age and Amount by P. Vietz and Ellie Lax meant to show the effectiveness of ABA therapy for the population with ASD, just like it's been demonstrated in numerous other experimental and randomized controlled trials that had shown the beneficial effects of cognitive, language, and social skills as a result of ABA-based interventions. Some individuals with ASD are particularly adept at certain skills and tasks which surpass those skills of neurotypical individuals. These special skills, these gifts, as you may call them, may include exceptional memory, math skills, artistic and musical ability, and the ability to focus intensely on something that interests the individual. Those results suggested outcomes of socialization, communication, and expressive language may be promising targets of ABA-based intervention involving children with ASD. However, significant effects for the outcome of autism general symptoms, receptive language, adaptive behavior, daily living skills, IQ, verbal IQ, non-verbal IQ, restrictive and repetitive behavior, motor, and cognition were not observed in this study. However, the overview of the study does show that ABA intervention-based interventions are beneficial, the ones observed, obviously, and even more so when created, implemented, and monitored by a multidisciplinary team, including the children's parents. Two additional ABA teaching styles are discrete trial training, DTT for short. DTT uses step-by-step instructions to teach a desired behavior or response. Lessons are broken down into their simplest parts, and desired answers and behaviors are rewarded. Undesired answers and behaviors are ignored. Pivotal response training, or known as PRT, takes place in a natural setting rather than clinic setting. The goal of PRT is to improve a few pivotal skills that will help the person learn many other skills on their way to reach their full potential. One example of pivotal skill is to initiate communication with others. Aunt Baba, 2018. Discrete trial training is the most traditional ABA technique. It involves teaching individuals one at a time using several repeated teaching trials and reinforcements that may or may not be related to the skill that is being taught. DTT is a method of instruction in which there is usually one instructor with one learner, and single trials are usually done en masse, called massed trials. Mach and Hall, 2016. DTT is also called the Lovaas method after its founder, Dr. Ivor Lovaas. DTT sessions are often 2 to 3 hours long and include short periods of structured time, 3 to 5 minutes to focus on tasks. Short breaks are often taken during the end of the therapy sessions. Free play and breaks are used for incidental teaching and practicing skills in new environments. Most DTT programs consist of 25 or more hours per week of therapy. The principles and technologies of ABA can also be provided in a naturalistic fashion that is child-led and uses natural reinforcement opportunities. Autism Speaks, 2020. PRT, Pivotal Response Treatment, was developed by Dr. Robert L. Kogel and Dr. Lynn Kern-Kogel of Stanford University. It was previously called Natural Language Paradigm. This approach has been used since the 1970s. It is a behavioral intervention model based on the principles of ABA. Pivotal response treatment is one of the best studied and validated behavioral treatments for autism. It is play based and child initiated. Meitchen Hall, 2016. The goals of pivotal response treatment are many, but they include development of communication, language acquisition, and positive social behaviors, as well as relief from disruptive self stimulatory behaviors. Rather than target individual behaviors, the pivotal response treatment therapists targets pivotal areas of a child's development, including motivation, response to multiple cues, self-management or self-regulation, or initiation of social interactions. By targeting these critical areas, PRT produces improvements across other areas of sociability, communication, behavior, and academic skill building. Motivation strategies are an important part of PRT. These emphasize natural reinforcement. For example, if a child makes a meaningful attempt to request a stuffed animal, the reward is the stuffed animal, not a candy or an unrelated reward. Each program is tailored to meet the goals and needs of the individual learner and the school and the home routines. A session typically involves 6 segments, during which language, play, and social skills are targeted with both structured and unstructured interactions. As the child progresses, the focus of each session changes to meet more advanced goals and needs. PRT programs usually involve 25 or more hours per week. Therapists encourage everyone involved in a child's life to use PRT methods consistently and in every part of that child's life. Autism Speaks, 2020. If your child is between the ages of 12 to 48 months, another naturalistic form of ABA based interventions is called Early Start Denver Model, ESDM. It is a behavioral early intervention approach for children, and the program uses a curriculum that defines the skills to be taught and methods used to teach these skills. Therapy teams and or parents or both can deliver group programs and individual therapy sessions in either a clinic setting or the child's own home. ESDM was developed by psychologists Sally Rogers, PhD, and Geraldine Dawson, PhD, in 2010. The focus of this approach is for parents and therapists to use play to build positive and fun relationships with the child. Through play and joint activities, the child is encouraged to boost language, social, and cognitive skills. The Early Start Denver model is effective for autistic children with a range of learning styles and abilities. What's important is that the provider has ESDM training and certification. Parents are a crucial part of ESDM programs. If your child is receiving such therapy, the instructor can explain and model the strategies for you and your family to use at home. ESDM programs usually involve 20 to 25 hours or more per week of scheduled therapy. The Early Start Denver model is designed to be highly engaging and enjoyable for the child. Instructors teach skills within a naturalistic, play-based interaction. They teach skills on the floor during interactive play and others on the table, focusing on more structured activities. As the child develops social skills, peers or siblings are included in a therapy session to promote peer relationship. Autism Speaks, 2020. Since social communication impairments are a defined feature of the autism diagnosis, speech therapy is a common recommendation for children with autism. As a result, it is often researched, as was the case with this research from the Journal of Autism and Developmental Disorders from 2018, done by K. Mendak and J. Light. It was titled "The Family-Centered Services for Children with ASD and Limited Speech: The Experiences of Parents and Speech-Language Pathologists." Speech therapy for autism will target improving the child's communication, social communication, and interaction skills, as well as helping them become more independent and confident in their environment. Some of the speech therapy goals highlighted by Mandak and Light's 2018 research included establishing functional spontaneous communication. The first goal of any child who has autism is to make sure that he or she can communicate functionally and spontaneously. This means that the child needs to be able to communicate their wants, their basic wants and needs to those around them without needing to be prompted through it. Each child with autism will need this area of speech therapy to look slightly different. Some children will need alternative means to communicate because they won't be able to speak, such as PEC's tool. Others will speak just fine but will need help learning the right words to use in the right situation. A speech language pathologist will be able to customize therapy to meet the needs of each individual child with autism. Another goal is to improve social communication throughout the day. Again, the specific therapy techniques and strategies for this area will vary depending on the child and their individual needs. But the key is for this social instruction and support to continue throughout the day. Children with autism will often have difficulty transferring skills learned in one setting to a different setting. For that reason, they need to work on social interactions in more places than just during speech therapy. Educators and caregivers should carry over social instruction in other settings as well. It is important to teach children what behavior is socially acceptable in various environments. This includes what the child should do and say in social situations, as well as how he or she should listen and attend. For young children, those who we will be working with, you will choose goals for basic skills like listening to a teacher, answering a question, or following directions. Here are several strategies that have been proven effective methods of social instruction for children with autism. There's visual supports, social stories, video modeling, and role playing. On the next slide, we'll continue with Mandak and Light's research, but we'll talk about improving peer interactions. Since children with autism often have a difficult time with peer interactions, these skills must also be directly taught. All children with autism struggle with this to some extent as part of the nature of autism. However, you will target significantly different skills depending on the age and developmental level of the child you're working with. Some peer interaction goals for young children when it comes to speech therapy are play skills. Teach the child how to play with other children and get along during play. Responding to their name. Teach the child to respond when someone says their name. Establish joint attention. Help children tune into those around them. Furthermore, according to Mandak and Light's 2018 research, when the speech therapist trains other adults, the child will make faster progress with their communication skills because they will be getting the same instructions, same strategies from multiple sources and in different locations. They'll be able to practice those skills in a natural environment, at home, in the classroom, instead of just always in the therapy room. Educators and caregiver training for children with autism is necessary. Speech therapy services for children with autism can look very different depending on a lot of factors. Each speech therapist will need to determine which services will be best for each child. Here are some of the different ways that speech therapy services may be assigned to help the child reach optimal progress. Direct therapy minutes. The therapist provides direct therapy to the child, often in an isolated setting like the therapy room. This is often best for introducing a new skill when fewer distractions are necessary. Push in therapy minutes. The therapist provides therapy to the child within the regular education environment. This is often best for generalizing new skills to a more natural environment and modeling teaching strategies for the classroom teacher, just like Joanna talked to us when she came to visit us in class. Consultation minutes. These may be called different things, but these minutes are written into the IEP as time when the speech language pathologist will work with the classroom teacher or parents to show them the techniques that they can use to help the child learn to communicate in other settings. There are many different ways to serve children with autism, and adding more direct therapy minutes isn't always the best option. Each student needs an individualized plan, including a combination of different services. Finally, we look at other communication skills that may be impacting the child with autism. Once the child begins to make progress, we can begin to address some of the smaller issues that may be impacting the child's communication, as stated by Mandak and Light. Here are some of the few areas that may need to be addressed: speech sound errors, errors in grammar, problems asking and answering questions, difficulty in figurative language. According to this research, the aim of therapy is to improve a child's verbal, nonverbal, and social communication skills. It addresses challenges in language and communication among children with autism. Life is made up of meaningful everyday activities or occupations such as walking the dog, gardening, preparing a meal, painting, doing the laundry, and playing games. Occupations are part of life. They describe who we are and how we feel about ourselves. Occupations help bring meaning to life. When we cannot participate in daily occupations due to injury, illness, disability, or social and environmental circumstances, occupational therapists help find solutions to address the meaningful everyday activities of life. Occupational therapy also helps prevent disability or illness and enhances the way we participate in our communities and lives. Occupational therapy helps us engage in the occupation of living. According to the Canadian Association of Occupational Therapists, they use their knowledge of sensory processing, emotional and behavioral regulation, oral, fine, gross motor development, and task analysis to support learning and participation in young children. Occupational therapists bring a unique and comprehensive perspective in the treatment of children with ASD, and that they are highly educated and experienced to evaluate and provide intervention, both direct treatment and consultation to families, educators, and caregivers in the areas of physical, sensory, processing, and social emotional health in all environments of a person with an ASD. In addition, occupational therapists support the many transitions in life, such as from home to daycare, from daycare to school, from school to society, including vocational or productive work environments. Occupational therapists provides support to families through education, consultation, advocacy, and assisting with access to community resources. Furthermore, occupational therapists work with healthcare and other professionals in a variety of places, such as long term care facilities, community support services, family health teams, hospitals, and even the client's home. Occupational therapists also work with organizations such as government, policymakers, school boards, care providers, and community agencies to develop programs and resources, according to the Canadian Association of Occupational Therapists 2015. As with anything in life, if we're looking for pros and cons, we can find them in just about anything. In the evidence based early intervention approaches that we've covered, there are more benefits than concerns, in my opinion. The evidence is there, the science is there, the research is there in those methods and those techniques. That is not to say that 10 years from now, though the methods from today will not be barbaric or completely changed. But today, these are methods that will help children reach their full potential. And we can apply this knowledge from these researchers or from Mach and Hall's book by, in addition to keeping a growth mindset, keeping the lifelong learner approach. Don't get complacent. Research and studies are ongoing. You got to keep up to date with new or updated resources, studies, or practices to make sure that we ourselves are an accurate and factual resource for our parents that we interact with. If unsure, we got to ask questions, seek resources and answers, or seek assistance, someone that can help us. Work as part of a team to help get that child to their full potential. In addition to reflective practices, so that we can reflect on the work that we're doing, even pedagogical documentation. One can go farther and get specializations or accreditations like the AECEOs. As it's been repeated numerous times, there's no one size fits all approach. There is no one remedy for all. Every child is as unique as the evidence based approach that will be used for them, to help them, to support them. This research, this ASD presentation, was intended to allow me, a student in early childhood education, to explore an area of the autism spectrum disorder that was of interest to me in greater detail. And in doing so, and as it's been often repeated in different classes and different courses, is there's no one technique approach that is better than the other. As it's been repeated numerous times, every child is unique. As Joanne mentioned us in class during her presentation, you've met one child with ASD, you've met exactly that, or one child with ASD. The evidence is plenty. The research is almost overwhelming. And this assignment has shown me that it's out there, it's always coming in. There's new research being done every day. And I think part of our role, part of our responsibilities as an early childhood educator is to make sure that we don't need to know it all, but we have to be able to navigate everything so that we can be the steward for the parent. We can be the helper, we can be the support for the child. Much like the old adage goes, be the best that you can be, not just for yourself, but for the child we're interacting with. Because in the end, we are there to support them reach their full potential. It's been said and it's been said again, and we'll hear it over and over. But repetition is key. Much like with children with ASD, repetition is key. I know for me, if I want to remember something, I need to repeat it. So, on that note, there's no one approach fits all for children. Every child is unique. The research, the studies is always coming in. It is our duty as ECEs to keep on top of it. Not just our duty, but part of the code of ethics and standard of practices that we have to abide by. I hope this presentation was helpful. On the next slide, I've added some resources that may be helpful to you.